Welcome to Awesome Breathers Club. Good evening and thank you for joining the session today. I'm Shakila Devi Perumal, a consultant in pulmonary rehab and mental health and a founder of Lung Rehab Voyage. I'm really having a pleasure to have most of you joining here today, or whoever is watching this as a recorded version. I would warmly welcome to our Awesome Breathers Club. And this session will be recorded and it will be available in the Awesome Breathers Club Facebook group. I'm going to switch off my video for the next following slides so that the video quality is not affected. So, what is our vision of this Awesome Breathers Club? Our vision is very simple: to save the lives of people with chronic lung disease, to strengthen the connections for people with chronic lung disease, and to reduce the burden of lung disease on our nation, especially the NHS. We are living in the UK, so it's basically a huge burden of the chronic lung disease our NHS is currently facing. And our vision is to support that burden to be reduced. And our strategy is to provide a virtual support sessions for people living with chronic lung disease, carers and family, create a community of support, and deliver a combination of educational webinar, workshop, guest speaker, national and international, social and charity events. Our today's agenda is a session title is Understanding Your Lung Disease. So at the end of the session, you should be able to understand your lung structures, symptoms of lung disease, reflect on your actions and management of lung disease, and finally, some questions and thoughts to share. So I love this organ, a lung inside our body. It's one of the resilient organ. I should say it is the only resilient organ, maybe. And it serves as a resilient organ, the fact because we have two lungs and we can survive with one lung if there is no possibility of the other lung to be healthy. And that is the good part of our lung, where we have been designed in a way that we are able to survive with one lung. And as you know, like the way we are actually doing everyday function cannot happen without oxygen. And our lovely resilient lung is the fuel station of oxygen and a cleanser of carbon dioxide. Without doubt, it is resilient, but it is at the same time fragile. It is more susceptible to any kind of irritants. And that is the thing we are going to deal with today, to understand our lung structures, how fragile it is, and how susceptible it is to the irritants, and how our people with chronic lung disease suffer from those conditions. And every breath counts, as you know, and our lung can hold about 6 liters of air inside, which is both mixed of oxygen and carbon dioxide, and a part of nitrogen as well. And our lung function actually is a very interesting thing in our body. Our lung function, as I can show in this graph here, it increases from the age of a well-developed lung appears for a child at age of 2. And from the age of 2, the lung function strengthens and the endurance of the lung is improving, and the lung becomes stronger and stronger and stronger up to the age of 35. And after 35, as you can see, it's actually slightly declines. And as you can see on the slide, there are two terms which I posted here: forced vital capacity, which is the maximum amount of air which you can exhale, and there is a little remaining after the exhalation. So the forced vital capacity of your lung declines 10 milliliters per year after the age of 35. And the forced expiratory volume, which in 1 second, that is FEV1, which is the main thing which every physician, actually, if you go for a lung function test, measures this, and that declines 1 to 2% per year after the age of 25 years. So, how is our structure of a lung designed? A lung, as you can say, there are the three dynamic pillars of lung. It's the airways, and the lung parenchyma, or the tissue, and the lung blood supply. The airways is the windpipe, as we call this airways, which is covered with little ring-like structures, which is cartilages. That's trachea in scientific term, and that actually then branches into bronchi, and that's the area when it is getting inflamed. We call this chronic bronchitis. So that bronchi then branches down into bronchiole, and that bronchiole then ends up in small, tiny air sacs. And these air sacs, in scientific term, are called alveoli. And our lung as a structure is covered by a layer called pleura. And this is also subjected to irritants and gets inflamed. And that condition is called pruritus. So this is a basic structure of our lung, and I believe so. It is very important that we have to understand what are the structures. We all would have learned in our primary education our structures of our lung, but as we grow, we have a tendency to forget what are the structures. So I'm just going to refresh this so that it's easier for us to go through the following slides. So the main condition, which is a burden to our nation and to the whole world, the 2011 statistics says it's 64 million of people suffering with COPD. And now the statistic has grown up more higher. And in the following slide, I will actually explain to you the statistic which is captured in NHS. But for the moment, this slide is basically showing you what are the conditions we hear from our physician calling us. You have chronic bronchitis, you have asthma, you have emphysema. Those are all pointing to the structures of our airways getting inflamed. So our airway starts from the trachea to the bronchi and the bronchiole. These are the airway structures. And the end part of the airway is the air sac. And this is the end part of the air sac, which is also involved in the condition called emphysema, where this particular contact, where you can see the arteries coming in contact with the air sac, that particular part becomes very impermeable and the oxygen or carbon dioxide cannot pass through. That is called emphysema. And in terms of the asthma, what most people actually aware of hearing from our physicians, and that is basically the airways getting inflamed. And that actually is a temporary incident happening inside our airways, exposed to irritants, and that gets inflamed temporarily and then resolved with the inhalation of medication. And the ongoing process of asthma then develops into chronic bronchitis. And some cases, it might end up in interstitial lung disease or sarcoidosis, in addition to the exposure to other environmental irritants like the chemicals, occupational dust. So whatever the lung condition we are having, it's all the combination of factors we have been exposed to. And one of the main killer disease, the COPD, which is a chronic bronchitis, mainly caused by smoking, is the inflammation of the airways. Irritants passing through the trachea and the bronchi, and this particular area is getting inflamed in our body. And the other part of the other condition, which we are very, very familiar, and one of the most the leading causes are lung cancer. And the lung cancer is basically the lung tissues are getting inflamed and the masses are formed in the lung tissues. And the other main pillar of our lung is the lung blood supply. The lung has two ways of blood supply. The blood supply to the interior parts of the lung, and the blood supply itself from the lung towards the heart, the pulmonary circulation, we call it in scientific word. And when this is also getting actually affected by the changes in the airways and the pressure changes in the exchange part of the alveoli and the pulmonary artery, which is it ends up in pulmonary hypertension in some cases. And that is another condition which is more familiar in the chronic lung disease population. So I hope so. I've given a pretty much idea what are structures of our lung and what are the different conditions and how those conditions are relating to our structures here. And before I could end this, move to the next slide, for your information, there are 300 millions of alveoli overall in our lung. And you can imagine that when you are saying that the lung function declines from the age of 35, slowly and slowly, these small alveoli are getting affected. It's not the whole of the lung getting affected at one stage, but it is going to be happening in the later stage. But slowly, these alveoli are just shutting down because of that progressive decline in due to our aging. On top of it, if a person have any other risk factors, like smoking or any irritants exposure, that's going to aggravate our decline more faster. So, as I mentioned, I'll be exposing some of the NHS evidence here. Respiratory disease is affecting 1 in 5 of the people, and it is the third biggest cause of death in England after the cancer and cardiovascular disease. And the lung cancer, pneumonia, and chronic obstructive pulmonary disease are the biggest cause of death. And all lung conditions, including the lung cancer, directly cost the NHS about 11 billion annually. And our NHS have a long-term plans, putting the priority to attend to the respiratory disease and to improve the pulmonary rehab availability around the primary care and community setting. But it is actually on the long pipeline. Now, when we're talking about the risk factors, when I say that a lung is getting exposed to irritants, and these are the irritants and risk factors of the lung, and the structure is getting inflamed. The primary one is the smoking, and that's the prime cause of the COPD, chronic obstructive pulmonary disease. And the second most important thing we have to look into is the air and the household pollution. And WHO has actually now put on some guidelines to how to improve our air quality, and the guidelines which I've actually uploaded in the Lung Rehab Voyage website. So those guidelines actually are targeting on the action plans to improve the air quality overall in our environment and to support the reduction of the chronic lung disease. And when we talk about the household pollution, it is the passive smoking. If an household member is smoking, that's one cause. The other members who don't smoke are a passive smoker. And the secondary thing is the form of energies they use in the household. That is another one, actually. Some houses in some of the developing countries might use some of the wooden hoods for burning. That might be another cause. And even in Europe, during the winter time, we burn hoods. So it is very important that we have a track on the carbon monoxide levels inside our house, so that we are not actually a victim of exposing our lungs to, say, irritants. And the other risk factor I would like to point out here is the socioeconomic status. And studies and researchers have confirmed people with lower economic status are more prone to get involved in smoking and other kind of irritant inhalation like vaping. And the other main socioeconomic status would be a factor with a mental health illness. Most people with mental illness may actually be falling under a lower socioeconomic status, and they might be consuming a poor nutrition, and also may be exposed to some chemicals, occupational hazards, and that might actually cause a huge impact on our lungs and become a victim of chronic lung disease. And as I already mentioned, our lung function declines after the age of 35. And if you're an inactive person, not having a good nutrition and falling under the category of poor socioeconomic status, you might be one of the victims of chronic lung disease. And also post-tuberculosis, as the lung has been exposed to inflammation, airways have been exposed to inflammation, that might be actually be one of the other causes that you might be having a chronic lung disease. So adherence and ritualistic behaviors towards your medication and lifestyle management is very crucial to have a healthy life and to manage your chronic lung conditions. And the other interesting factor is the genetics. So, as I already mentioned, like in my patient population, I have witnessed some of the persons who have not been a smoker, and no one in the family have been a history of smoking, but still have chronic obstructive pulmonary disease. That might be the reason because of their genes. That might be their ancestors had some of the chronic lung disease, which I put on the box earlier in the previous slide, maybe chronic bronchitis or emphysema, that might be passed on to their genes. And what is this term AAT is adenosine triphosphate. It is actually alpha adenosine triphosphate. It's actually a protein which is responsible to maintain your air sac elasticity. And if that is deficient, and that leads to the condition emphysema. And so people with emphysema need not be a smoker, but it can be due to the fact that they are having a lower levels of AAT in their bloodstream. So that is another risk factor for chronic lung disease. So you've actually now been exposed to the structure. You have understanding of what are the risk factors. So what are there are different lung conditions I pointed out in the previous slides. So all of those lung conditions majorly have these three main symptoms, the primary symptoms which I can point out. So first one is an increased shortness of breath. People actually, when I say shortness of breath, even if I am actually going out running and I'll be getting short of breath, I'm not talking about that shortness of breath. But people with chronic lung conditions might not be able to function the daily activities, simple daily activities like getting out of the bed and moving into the kitchen, or lifting something from a high-level shelf from the kitchen down to their cooking table. So those kind of shortness of breath we are talking about here today, and not able to maintain the daily functional activities. And those are the important symptoms a patient might be exposing. Okay, might then trigger further investigation, going to your GP, asking for further diagnostic tests. And the productive cough, the other main symptom is a productive cough. With any of the chest infection, our lung is a very resilient organ, as I mentioned already, and it is so well designed that it actually traps any of the antigens into our body. So any of the virus or bacteria coming into our throat, into our mouth, it is or the nose, goes into our throat, and there are receptors, cough receptors in the throat and through the tracheal pathway, which actually triggers cough to cough it out. Okay, it's one of the protective mechanisms our body has been designed, and that is actually to be noted. Though it is a protective design, then that is also one indication there is something going wrong in our body, and some antigens are passing through our body, and that is actually trying to increase the phlegm or the sputum, which we call scientifically, and that is to trap the viral or bacterial agent. And if there is an increased sputum production, that is another indication that you are suffering from lung disease. And the other final symptom, which are the more common primary symptoms, are the change in mucus. So normally everyone actually secretes mucus more than 100 ml per day. And the mucus color is, most of them have a clear mucus. And the people with chronic lung disease, if you actually ask them what is the color of your mucus, they would say slightly yellow or slightly green. And that is their normal color of mucus. Okay, so it is actually, if that color is changing to any of the darker colors, then that particular condition should be taken very seriously. That is, it can end up in pneumonia. So they should be making a sooner visit to their GPs and get further investigation of this sputum and also further diagnostic tests. So these are the common primary symptoms which should trigger you or prompt you to go to your GP or to your local hospital to get tested further to get earlier intervention. So what are generally the screening or the diagnostics happening around? The normal diagnostic or the screening happening on top of your physical examination, your physician will be doing, is measuring your oxygen level, which is the pulse oximeter, and also sending you for a pulmonary function test. What is this? This is basically, as I mentioned earlier, the two terms, if you remember, the forced vital capacity and the forced expression volume in the first second. Those are actually, along with that, there are other several volumes and capacities being measured in this test. It's basically to identify which structure of your lung has been affected and whether your total lung capacity is good, or whether you fall under the obstructive pattern of lung disease or a restrictive pattern of lung disease. So this is a very vital test that the patient is sent to. If the patient has been exposed to 2 or 3 of the risk factors which I mentioned in the previous slide, and the patient has a crossed age above the 35, and this is the primary test they have to be sent to for screening and diagnostic. And further to that, your physician or your consultant might actually order some blood tests for you to rule out the C-reactive protein. If there is an infection, a C-reactive protein is a component in your blood that might show us increase straight away, and that indicates that you have been prescribed some antibiotic because there is some antigens are passed into your body. And there are other white blood cells and red blood cells. The general blood profile will be tested to make sure that everything is normal in your blood. And your doctor or a GP might actually send you for echocardiogram. Why echocardiogram? Because your lung and your heart function is more interlinked. Okay, so your lung is a main organ which actually sends the oxygenated blood to your heart, and the heart then sends the deoxygenated blood into your lung. So it is like a circle, a catch-22 here. So if your lung is actually weak, it sends a back pressure, and your heart, particularly your right heart, might be loaded, and that is called cardiac asthma in the scientific term. And so to rule out if there is any of the lung impacting your heart, or your heart symptoms itself might actually pretend to be your lung symptoms. And so we have to rule out whether it is mainly your heart function being affected or your lung function being affected. So that's very important that you'll be sent to an echocardiogram. And further, the imaging, the chest X-ray, the CT scan, and lung biopsy, and bronchoscopy. These are the other tests you might be exposed to, and your doctor might be wanting to do if he or she believes that you are more eligible to go for further investigation. So what are your actions? So first of all, when you are, now I've actually mentioned several risk factors and how your lung functions and what are the symptoms. So when you identify your symptoms, with the primary 3 symptoms especially, and if you have been exposed to any of the occupational or environmental exposure, it would be a good idea to report to your doctor. And also, while you're talking to your doctor, understand what is the purpose of a diagnostic test or the prognosis the doctor is expecting out of your diagnosis. This is very much needed that you actually talk to your healthcare provider, whether your GP or your respiratory consultant, or nowadays in the respiratory area, the allied health professionals are performing the lung function test, the physiotherapist or the nurse. So you need to be, whoever is performing the test, you have to confirm clearly what is the purpose and the diagnostic and the prognosis. And when it comes to lung management, it totally relies on your accountability to adhere to your prescription, whatever the prescription, medical or non-medical. So I will be going through in the following few slides what are the non-medical prescriptions, what you can do from your side. If you are a smoker, please quit smoking or vaping to avoid any irritants to your lung. And if you are using or prescribe any inhalers, it is very important that you adhere to your inhaler prescription as prescribed, because evidence confirms that if your adherence of inhaler prescription reduces the frequency of your exacerbation and also slows down a progressive decline in your lung volume. And get vaccinated. Usually, like we advise all the chronic lung disease survivors to vaccinate with a flu vaccine every year. But we are also faced with another challenge of COVID-19 for the past over 24 months now. So we have to be more in line with both the vaccination at the moment if you are a chronic lung survivor. And practice correct posture. very, very crucial and important. Though it sounds very simple, it is very much having a huge impact on the way you breathe and the way your lung volume and capacity operates. So impaired posture is going to have these ailments: soreness and pain, numbness, poor digestion, negative mood, low self-esteem, and poor circulation and fatigue. And the correct posture would prevent those, and it would prevent the pain, it improves your mobility, it improves your breathing, it improves your feeling, improves in a way of positivity and higher self-esteem and good circulation, energy efficiency, and improved concentration. And you feel and look good. And the other slide, I would like to point out food and therapy. I named this slide food and therapy basically because food is a therapy. If the Asians are watching this version as a recorded version, food is a therapy, and there are a lot of medicinal effects and values in the Asian food. And particularly to point out the turmeric, which has an antiviral and an antibiotic as well effects, and the ginger as an anti-inflammatory effects. And eucalyptus has a bronchodilator effects in it. So these are the three important things which I would like to point out, expose to people so that they can benefit from it. And a regular exercise is very crucial. A regular exercise improves your lung capacity and strength and endurance, and also reduces the frequency. When I say exercise, don't think about committing yourself to a gym or a gym regimen, which most of us, including me, is not very good at adhering to the gym repetition. So in terms of activity, exercise can be put down to any of the physical activity which can improve our daily functions. It can be a casual walk, and make it as a routine, and 60 minutes of walk every 4 days in a week. Or yoga, or any of the flexibility kind of exercises which you like Tai Chi. So there are loads available out in the markets of physical activity. So you can choose one of those activities and put on a regimen and have a mixture so that you are able to adhere to the regimen. And the final one I would like to point out is, and also in the climate of the COVID-19, it is very important that you avoid crowds. Basically, we advise chronic lung disease sufferers to avoid crowds because their immunity levels are very low. But it is very crucial at this minute that most of us needs to be, who are even not the victim of chronic lung disease. If you're watching this as a record version, it's a bigger plea I would like to put out in the session, that please avoid crowds and wear appropriate gadgets like masks and gloves if it is needed, if you're going into any of the food venues or anything. So that is all I have in stock for you today, and I would like to share this as a small mini version of a discussion from the basics of the lung up to what we are exposed to, and so that you are able to reminded of, maybe I would say it's a reminder for most of the people who have been watching here, to know about how to manage your condition. Though it sounds simple, it is very hard to make it as a regimen and a regular practice. Now, I would actually open this for discussion and question. I see that only one person here today. I would actually ask if any questions.
Hi, Devi.
Yeah, hi, Kavita.
It's very nice the way you have explained it. Very beautiful, very simple and nice, to the point. And I really enjoyed it. It's a nice recap.
Thank you, Kavita. So I'm happy that this is the main aim of this Awesome Breeders Club, to educate in a very simple term so that we know about the condition. And also this is not only for the people who are suffering from chronic lung disease, but also people who manage their family members with chronic lung disease. That is the main aim, and I'm happy that we have achieved that goal today.
Yeah, thank you so much.
Thank you very much. So as we have come to a close, if there is no other question, Kavita, from you, then I can bring the session to a close. And I will see you in the next session in the social hour.
Yeah. Regarding COVID